invitation to present to you today the work that we've been doing within the NIHR evaluating or looking at remote methods of trial delivery. So as Simone mentioned, and as is mentioned in the full title, the programme of work arose out of the situation that we all found ourselves in early in 2020 when COVID struck, and a lot of trial work ceased, of course. And in order to get our portfolios up and running to any extent, lots of centres here in the UK, and I'm sure elsewhere and with you in Ireland, it became very clear very quickly that we had to do things differently. And then as we've emerged out of the pandemic, and indeed driven by findings within the pandemic, it became equally clear that some of what we needed to do differently involved being more inclusive, not least because of the populations which are hit hardest by COVID, but also as vaccination programs have rolled out, making sure that everybody, that we take everyone with us as we try to improve the health of the nation. And some of the drivers for health inequalities are of course underpinned by inequalities that extend right the way back to when healthcare interventions are conceived, designed, trialled, and then implemented. And if that isn't done in an inclusive and equal way, then we're just perpetuating the inequalities that we are now living with. So that's sort of the background, but as you'll appreciate, that the COVID really accelerated our experience of living with COVID and trying to deliver research in COVID has really accelerated, I suppose, a sea change, and that was indeed happening anyway. And so there is the opportunity, taking those learnings, taking those new methodologies of embedding them into our future work. And that's really why this programme of work is continuing, is to take those learnings from COVID and say, well, what have we learned? What can we now do differently and better that is going to better meet the healthcare needs of the nation? And importantly, of course, this isn't happening in isolation. Health and care research is mapped to our health and care delivery models, and those are also changing as a result of COVID. So footfall through outpatient clinics is reducing, patient care is delivered closer to their homes, it's delivered using new technologies and using remote methodologies. And if we're going to map research opportunity to those new clinical care pathways, then we need to change what we do. We can't just rely on clinic footfall. And we can have greater understanding of what the clinical needs are, where we want research to be based, and that can be done at regional level. So I'm sure you'll have seen that the heat maps of disease prevalence, and whether that maps to where research activity is taking place for cardiovascular disease or diabetes, excuse me, it can be populations within regions. So particular communities, I work in Devon, so for us, are we really engaging people that live in rural communities or coastal communities or more deprived communities in research? How does that map to where their clinical care is accessed? And then within populations, we can subgroup different patient groups or clinical cohorts. So for example, those with multiple morbidities or with particular features of their disease or condition, which mean that they're not eligible on the whole to take part in studies. And some of those we can address with new methodologies. And having a better understanding of what the needs are for our patients in terms of care will allow us to plan how to deliver research. And there are new opportunities available because of the developments that have taken place over the last couple of years, particularly relating to remote methods, some novel technologies for measuring things, for accessing data, for accessing people through communication tools. But in this new way of working, it's very important, of course, that we need to be alert to unintended consequences. And as we engage more with one community, even if it is a broader community, that means that there will be others who are not engaged with, and we need to understand that. So that's why the project is being taken forward, and some of the thinking that's driving the themes that I'm going to talk about. So the project, as you'll have appreciated already, started in 2020 because of the COVID situation. But we are now contemplating taking those learnings through into our future way of working. So this will extend, we're planning now the next phase of the project through to March 2023. So what I'm going to talk about is each of the phases of the project, how it evolved, what we did, what we learned, and our steps moving forward. So in phase one, which was essentially trying to think, COVID had just hit hard. A lot of our studies had ceased. Lots of study teams around the country were trying to develop methods for getting studies up and running, existing studies and new studies. Protocols were being amended, and clinical trial delivery teams were trying to develop new ways of working, and lots of people were doing this, not in isolation, but lots of people were doing the same thing. So there was a space for sharing best practice, shared learning, and sharing the understanding around the benefits of a different way of working, what the pitfalls were, what the challenges are, what the enablers are, to support teams in changing the way that they were working. And so a collation of information and a toolkit was a primary aim of this initial phase of the project. And so how we set this up was within our cluster within the NIHR Clinical Research Network. So we are divided into clusters, and at that time our cluster E is neurodegenerative diseases, dementia, neurology, aging, and genetic disorders. So this was a project that we developed within our cluster, but had broader stakeholder engagement throughout other disease areas within NIHR. And we also interacted at that very early stage with the hospital R&D departments. We made sure we had patient and public involvement representation on our initial working group. And we also had representation from clinical research organisations, who of course were also trying to get portfolio up and running. And one of the first things that we had to do was define what we were talking about, and it still isn't entirely clear what we're talking about, in as much as there are many terms that are used, some of them interchangeably, and they might mean slightly different things. So another term which is often used is decentralized trials, and I would say that what we were addressing forms part of that, but not all of that. So for our purposes, what we were talking about with remote methods of trial delivery was all activities undertaken to deliver a clinical trial or a study that does not rely on in-person or face-to-face contact. So it would extend to a telephone contact or postal contact, but it does not cover a home nurse, for example, or a visit which is just taken outside a study centre, which is within the remit of a decentralised trial, for example. So when we thought about the trial, obviously the patient, the participant, is absolutely central to a study, but there are all these processes that go on when we're delivering a trial, and all of these needed to happen differently, from recruiting the participant, delivering the intervention, measuring the outcome, and then the quality assurance processes, study monitoring, source data verification, all those sorts of things all had to happen with remote methodologies. And when we're thinking about the patient, of course, there's how do we support the patient in the study? How do we train them in their study requirements? If they have to do diaries at home or particular bits of the intervention at home, how can we make sure this is a positive experience for the patient? And of course, not forget another very important component, which is the care partner or carer supporting the patient in the study. And all of these things needed new methodologies to support. And as I've alluded to, we weren't just thinking about the delivery of the intervention and the outcome assessment, but excuse me, particularly as new studies were coming onto the portfolio, everything had to be done differently. So there's the possibility of using remote methods, and some of these stages, of course, will have been done using remote methods, from site identification all the way through to site closeout, and actually even beyond that, disseminating results. So things like site initiation visits, investigator meetings, identifying participants, getting informed consent, actually doing the doings of the study, including dispensing the drug accountability, the monitoring that I've talked about, managing paperwork and source documentation, and then having the closeout visit remotely and the dissemination of results through virtual meetings and those sorts of things. So the whole trial journey has the potential there for being delivered in a different way. So what we did in this first phase of the project was seek out what was happening already, scope out where activity was taking place and what had already been learned, and what were good examples of what worked and challenges which meant things couldn't work. And we got this from the perspective of the public, patients and care partners, and from professionals involved in designing and delivering clinical trials. So we did this using surveys that were disseminated, and from the patients and care partners and members of the public. What we wanted to know was what had worked well for them. Had they been part of a trial which was partly delivered remotely or not? And what didn't work, what doesn't sit so well with them. And the questionnaire that we sent out was importantly co-developed with our patient contributors. And then we sent out a separate questionnaire to professionals involved in delivering trials, asking them what they felt were the benefits, the pitfalls, what were the challenges, what were the enablers, and again, any good examples that they could signpost us to of things that were happening that they thought worked really well. And we were also interested to understand from the professionals where they felt the knowledge gaps lay. So this is a skip through what we did over maybe 4 months or so. So we had a couple of meetings where we formed our subgroups around those themes: participant experience, recruitment, intervention delivery, outcome measurement, quality assurance, and sent out the survey to get feedback on these themes and domains of activity, and then pulled out the key challenges, barriers, pitfalls and enablers, extracted good examples of best practice to map against each of those activities, and then created our deliverables, which was a preliminary guidance which we put on the website, thought about what the key principles should be for remote methods of trial delivery, and how we were going to maintain stakeholder engagement in disseminating this. I thought it'd be helpful if I just talk through some of the responses that we had, particularly from our public survey, to pull out and illustrate some of the themes that emerged. So we asked people, what did you feel, what they felt the advantages were of remote methods of trial delivery, and they fell into several domains. So a large advantage, of course, was time, that participants aren't pinned down to a specific time necessarily for a study visit. If it's a questionnaire that can be done online, people can do it in their own time, and that, of course, is much more inclusive for people who might be still at work, for example, or who have caring responsibilities, and it did mean that it was less disruptive for carers if there was that flexibility around the timing. At the time, of course, COVID still is prevalent, but with a slightly different nuance back then. So reducing the risk of COVID infections and coming into a hospital site, which is, of course, a higher risk environment than being in one's home, patients valued that. Of course, just having an appointment in itself can be stressful, and patients appreciated not having to come in for appointments. There is all the hassle of getting to a clinic, parking problems, being on time, which was, of course, taken out if that isn't part of the process. And it did mean that research opportunity is accessible for people that might not live close to a study centre, that some of those geographical boundaries are overcome by delivering things remotely. And of course, it might be a geographical, a distance issue, or a connectivity issue with public transport not being readily available, for example, or it might be a disability or accessibility problem for particular patients with mobility problems. However, there are disadvantages that were also highlighted in our survey, and the issue of inclusivity certainly came up, that engaging in digital health technologies to take part in the study will of course exclude certain groups, and that that might mean that the participants that one gets are actually less representative of the social and cultural diversity that we're hoping we'll be able to access. Lots of IT problems, glitches, website access, connectivity problems, and actually just being used to using technology, digital literacy within the patient population. Delivering things remotely is a different way of communication. This is different. This is a webinar compared with giving a talk live in an auditorium. And so there are issues around that might need to be mitigated for patients and participants. So for example, you can see my hand waving, but you can't see all of my body language. And of course, if people don't have video capability in the technology that they're using, then they won't even have facial expressions, and that can diminish the communication experience. In these sorts of fora, as I'm sure you'll have appreciated, sometimes the sound can be distorted. And of course, if instructions and processes without the ability to talk someone through it and demonstrate in a hands-on way are delivered remotely, then it can make it more difficult to understand. And a large part of what participants enjoy in study visits is having the time to connect with the delivery teams, with the research nurses and the research practitioners, the cup of tea, the chat, the shared joke, that's very important to study participants, and that can be lost if we're not careful in delivering trials remotely. Interestingly, the participants also commented on validity, which is something that exercises the investigators, I think, a lot, that how do we know that an assessment or indeed an intervention is equivalent if delivered remotely? Some of them might intuitively appear to be, some of them is intuitively more of a stretch, and it's clearer that some validation work needs to be undertaken. But the participants also highlighted this. They weren't sure how the assessment scores would compare if done remotely compared to face-to-face. And of course, that as well as validity, there are also other aspects of data integrity, data completeness, and it might be that for some outcomes, it isn't possible to get them remotely. The participants and the carers also highlighted support problems, that if they're struggling with a particular study-related task, that it's more difficult to get help. They wanted to have somebody to contact, and they felt that was less there. They didn't feel supported, and then if contacts are more infrequent, or it's not as apparent how support can be provided, then they're feeling that they're having to sort of stack them up so that when there is a contact, they can then run through a list. And then an important concept of feeling valued, that patients felt that they were a number in a study as opposed to a person, a participant, and they felt the experience was impersonal. And of course, that sort of sense of value is really important for retaining people in studies, and is something that we need to address. So based on those sorts of comments and similar comments that we got back from our professionals survey, we developed the Remote Methods of Trial Delivery website. It's a Google site. The web address is on the slides. And what it includes is our preliminary guidance, explanation of the background, definitions, and some examples of best practice relating to overall guidance, other organisations, just general guidance around the process, but specifically for recruitment, interventions, how they could be delivered remotely, how outcome measures were delivered remotely, including blood tests, those sorts of things, supporting the patient experience with virtual coffee mornings, and quality assurance processes, such as remote source data verification and remote closeout visits and remote site initiation visits, all the things that we're very used to now, 18 months down the line. And we also, on the site, have articulated our agreed principles. that obviously our national standards for trial delivery best practice should continue to apply, and that sort of feels like a given, but actually things can very easily slip. And I'm thinking particularly here of the simple things, maintaining source data, maintaining the paperwork, the delegation logs. If that's done remotely, it's very easy for the signatures to be slightly out of sync on one log compared to another, and those sorts of things. So we really have to make sure that all of the effort that's been put into developing our robust processes for data integrity and PI oversight and all those sorts of things, which we're so used to doing in our traditional delivery models, that we maintain those same standards as we switch to a different way of working. We should use the opportunity to maximise inclusivity and be really careful about not doing so. And that will include, to a large extent, connectivity problems and digital literacy problems, not only amongst potential participants, but also amongst research delivery teams. So we need to be mindful of that. We should not assume that what we do in one way is going to be equivalent if we do it in a different way. On the whole, for a large number of things, that will be the case, that they can be considered equivalent, but that is an assumption, and at some point those assumptions need to be tested. I've put here that trial delivery should be cost effective. There will be things which cost more. There will be things that take more time, and particularly if we're transitioning to a new way of working. However, the overall impact should not be that this is much more costly or much more time demanding. There will hopefully be savings for both cost and time in other domains of delivery, and that needs to be evaluated and articulated. And for any new methodology, so not translating an equivalent into translating what we hope is equivalence, but actually developing something new, using wearables, for example, which we hope will give us new insights into disease or care, then of course these need to be robustly evaluated. Also within the preliminary guidance, we have listed what we learned around enablers at organisational level, at individual level, for developing and delivering new ways of working, the barriers and challenges that people experienced, pitfalls to watch out for, and based on that, some questions to guide research teams around the design of studies using remote methods, but also the delivery of studies using remote methods, and as I mentioned, some case examples of what works. And we have written this up in a short report in Trials, written by Jane Mazzoli, who's a working group member. So that brought us to the end of phase one, and this was in 2021 when Best Research for Best Health, the next chapter, was also released. And this, as you will recollect and know, has got 7 areas of strategic focus. And this work that we are engaged in, really speaks to at least 4 of those areas of strategic focus. So the first one is to build on the learnings and the research response to COVID to support the recovery of the health and social care system. And we are still trying to do that. We can bring clinical and applied research to underserved regions and communities, and remote methods being able to cross some of those boundaries might help with that. We need to embed equality, diversity and inclusion across NIHR, excuse me, including in our research delivery. And of course, very importantly, expand our work with the life sciences industry to improve health and economic prosperity. And this is an area of work that the life sciences industry is very interested in. So bearing in mind that report and these areas of strategic focus and what we'd learned already in phase one and where we'd got to, we thought there is definitely scope for doing more with this as we transition out of COVID and taking the best bits into a new way of working. But what do people want from that? And to understand what people want from that, we had scoping conversations with some of our key CRN stakeholders, so the MHRA, the Medicines Healthcare Regulatory Agency, the ABPI, British Pharmaceutical Industry, AMRC, representing medical charities, the Health Research Authority, the clinical research organisations, and clinical trials units through the UK CRC. And out of those, these were all one-on-one, if you like, scoping conversations, just to really understand what each of these stakeholders had experienced and were expecting and hoping for moving out of the COVID experience and into a new UK research environment, and what that might look like, and therefore what the CRN could helpfully do to promote that journey. And the themes that came out of those conversations was a clear desire to understand what has worked well over the last year through COVID, and to understand the potential benefits of remote methods of trial delivery in terms of meeting the challenges for trial delivery that we're facing today. So recruitment targets, inclusivity, retention. Those sorts of challenges are today challenges, as well as the challenges that we anticipate that we're going to have to face in the future. We also need to understand what is needed both at site level, regional level, national level, in order to enable us to deliver trials using remote ways of working, and that could be something like, broadband infrastructure. And then in amongst all of that, work out what is it that the UK can offer with these new ways of working, which will speak to our collaborators, both internally, nationally, and our international academic and commercial collaborators. So the overall objective of phase 2 was to facilitate trial delivery within the current challenging context, which was, as you'll remember from 2021, continuing COVID, a rolling out vaccination programme, and a portfolio which we're trying desperately to restart. And to use that energy to promote a sea change in the way that we think about future trials, both the design of those trials and the delivery of those trials, which will benefit, importantly, the participants, but also the wider clinical research community. So we set up a second steering group for our phase 2, and this was broader in reach, with representation there from the organisations that I've listed. And a key activity was to hold a much broader stakeholder event addressing these questions that arose out of the themes from those scoping conversations. So we held a stakeholder event at the end of last year, and these were our 4 main questions that we asked people to think about. So what are the benefits and risks of remote methods of trial delivery for participants? What are the benefits and risks for UK research and healthcare? How can guidance, and there is a lot of guidance, best support remote methods of trial delivery? And how can we articulate and maximise the UK offer for our various audiences around remote methods of trial delivery? It was a very useful and constructive day. We had breakout sessions and methodologies for capturing lots of input, and we invited, as I said, stakeholders across all of our representation across all of our stakeholder groups, including, very importantly, patients and public contributors. We also had a graphic artist capturing the conversations that we had. So I'm just going to go through them relating to those 4 themes, and apologies for turning to the side. I've got it bigger on my screen next to me, to my right here, and I can read the words better even with glasses. So for participants, a key benefit, if you like, was accessibility, both in terms of it being an advantage, but also a potential pitfall. So addressing accessibility of trials, but then accessibility of the technology. Understanding that less face-to-face contact also has advantages and disadvantages. Participants were also concerned about data security and trust in the system, and who's accessing data, where does it go if it goes into a cloud. who can see that data. Understanding how to communicate, and you'll remember this actually was flagged in the survey that we had done in phase 1, how to communicate, and making sure that those communication channels are made clear to patients if they are running into difficulty and do need more support. And another key theme that emerged was participant choice, that this is the opportunity to really design patient-centered trials whereby they have the flexibility and the choice to engage with the trial in different ways, and particularly if it's a long trial, to maybe change the nature of that engagement over the course of the study to maximise retention. In terms of research and healthcare, similar sort of themes, lots of discussion around participation, how that can be supported, but also from the perspective of the trial delivery team. So how do we get the workforce to have the clinical skills and the research skills to deliver studies using new technologies and new methods, and making sure that this is done in a way that meets our quality and safety expectations. There was also discussion around the design of studies and understanding what can be delivered best remotely, what needs to be delivered potentially in person, and around the validation and equivalence evaluations. In order to do this, of course, discussion around resources. Is it really going to result in less resources? I'm sure any of you that have been involved in remote monitoring will understand it rarely is less time consuming than in-person monitoring, and in some ways much more time consuming. So understanding that is important. And as we develop a new way of working, start to implement it, we need to evaluate it and make sure that it is delivering what we expect and isn't throwing up anything unintended. For the guidance, we discussed who exactly is the audience of the guidance, and our first Google site, if any of you looked at it, will appreciate that there's nothing there that is participant facing. It's very much a professional facing website, so that's a gap. So there has to be guidance somewhere for potential participants if they're thinking about taking part in a study that involves remote methods. What does this mean for them? What can they expect? We can use that as a forum to provide explanations around data security and those sorts of things and address some of those concerns. There will also be other audiences such as trial sponsors, trial designers, people trying to design studies that includes new ways of working or different ways of working. And so if we think about our audiences, we can map existing guidance actually very much to those audiences. So we're not really writing anything new, because there are some groups, lots of groups that have done some excellent work, and we see this as an opportunity to collate that and make sure it's appropriately targeted and disseminated, making sure that there is guidance there that's simple to understand, realistic, and helps the audience, whether it's the patient in terms of understanding what might happen to them in their data, or the trial delivery team as to how to do a telephone consent or a remote consent or remote source data verification or whatever it is. And then the last conversation was around the UK offer, and quite a lot of conversation around what had gone well with COVID, because things did go very well with COVID in terms of our UK research delivery undertaking of the COVID studies, the interventional trials. And I think that was a really positive experience for anyone involved in delivering the trials, and also seeing the implementation of the learning from those studies, that what can be delivered. And the UK is certainly seen as an environment that can be flexible and adaptable and pivot quickly. And one of the a main theme of the conversations that we had with both the HRA and the MHRA was that in actual fact there was very little that they had to developed that was new. Everything that they had implemented was pre-existing, and there wasn't the awareness of that flexibility, whereas now there is very much the awareness of the flexibility within the regulatory environment within the UK. And this is something that does allow us to adopt new methodologies, and we ought to maximise the potential of that. However, within articulating the benefits, the evaluation is really important, and also understanding the barriers to make sure, again, that inclusivity is maximised. So things like digital access, of course, is not consistent across the UK, and is possibly less consistent across the UK than other countries, not just for participants living in rural communities or, you know, valleys with no mobile phone reception, but or in different sectors of the community with socioeconomic drivers that make inclusivity hard to maintain, but also amongst healthcare organisations. The trusts themselves are set up very differently in terms of their data management, data access, use of an electronic patient record, the interoperability of systems, the disparate systems that exist within the UK, and the way that those integrate and streamline. All of this is a challenge that we as a clinical research network, of course, have to work within, not really influence, but maybe give a steer. So out of that stakeholder event, and I hope you get an appreciation from those infographics, the richness of the conversation, there were some key themes again that emerged. And the top theme is that what this will allow us to do, we hope, is to make trial experience much more patient centred, to offer patients flexibility as to how they engage in research and choice into the how, the where, the when. And that this will allow, of course, we hope, for more inclusive research and better quality research. There is still a need for clarity around terminology, which we are slowly achieving, but as I've said, I don't think we're quite there yet. Clarity around the information that can be provided, targeted to different audiences, and also clarity around expectations, what this will deliver for trials and for patients and for organisations. There's still a need for trust, both within the whole process, to ensure that the processes work in the way that we expect them to, but particularly trust around data. First, for the investigators, that they will receive good quality data, and that data integrity will be maintained, and for the participants as to who's accessing the data. And I think this is a really important barrier and challenge that we need to overcome. And within the whole process, the importance of relationships is something that we need to be mindful of. We also have to make sure that we evaluate the processes for implementing remote methods, that we develop an evidence base that supports their use, and that we evaluate the implementation. And then when we gain new knowledge as a result of implementing these new processes, we need to know whether that was useful or not. So there's a lot of evaluation work that needs to be undertaken. It's also, I think, highlighted that there were tensions within within the landscape, that we want, for as an example, we wanted the guidance to be flexible, to allow teams developing studies or delivering studies to map what was going to work best for them locally and with that particular patient group or patient population. But we didn't want it to be, so we don't need it to be so flexible that actually it's open to interpretation and means that processes aren't consistent. And there's also another tension around the pace of change, which I'm sure you'll all appreciate has just been frenetic, and it feels like isn't really showing much sign of slowing up. That the current pace of change is not sustainable, but there is another driver, which is to maintain momentum. We don't just want to fall back into our old way of working and not drive forward these improvements when we can see that they might be of huge benefit for us. Another theme that emerged was actually the breadth of the conversations. It isn't just around trial delivery, even the site identification, which is where I started. It's actually much before that, when we're designing the study and in those pre-award conversations, thinking about the costings and approvals processes. If we are going to have a different way of delivering the study, that will have impact in terms of cost and resource requirement, and the processes will be different. So that the breadth of the conversations and the people that we involve need to be more broad than we'd originally thought. And then at the other end of that sort of trial journey, how do we take our learnings and use those in changing healthcare delivery models? How do we ensure that we've got that pathway through to impacting care if where we're trying to have impact is also developing? When we're evaluating impact, what we hope, of course, is that this will result in better patient care, because there'll be better evidence on which to base healthcare decisions. We'll have impact on trial delivery, time to recruitment, the breadth of inclusivity of recruitment, retention rates, data integrity. We want to hopefully demonstrate that we can get more diverse trial participants, and that our trials will be inclusive. And in order to do all of this, there will be an impact on funding, that if we are going to implement new ways of working, that will need additional resource attached to it, and we need to be mindful of that. So we left that with a stakeholder event, and are thinking and summarising subsequently that there's certainly a lot of work to do. So for funders, sponsors and regulators, what does a flexible trial look like? Is it possible to have a flexible funding model? You know, if everyone's having remote assessments, does that cost a different amount to if everyone's coming to clinic? How can a funding model support delivery of a flexible patient-centred trial? For the methodologists, what are the methodological consequences of having hybrid delivery models? If some patients are having an outcome assessed in a particular way, or an intervention delivered in a different way, what does that look like in terms of evaluating that study? And how do we understand what aspects of trial delivery are feasible to be delivered remotely, which could be recruitment, for example, but may not be, such as an intervention? And then what is the feasibility of remote data collection and maintaining data integrity and data completeness, and also its acceptability? And that acceptability will vary potentially dependent on the participant group. So some participant groups might be much more hesitant to share digital data, or less able to use digital health technologies. There's definitely work to do within the NIHR CRN, so a large piece of communication work, maintaining engagement, building trust in remote methods of research delivery with the public, as I've talked about, but also with the workforce, making sure that we have got an adequately skilled workforce, and investigators who will be potentially quite used to delivering traditional trials using a traditional delivery model. And if we want people to think about delivering a different sort of trial with a different delivery model because it's more patient-centric, and particularly if it's a hybrid, making sure that the investigators trust the methodologists and the whole process and infrastructure that we have to support that. And of course, there's work for us to do as the NIHR Clinical Research Network in implementing new ways of working and measuring impact. So on the basis of those considerations, we've now starting to design moving from phase 2 and into phase 3. And phase 3 really will be dissemination, implementation and evaluation. I think at least some element of remote methods is becoming much more embedded in trial protocols, and so there's certainly scope, and it's now timely to start thinking about evaluating that and making sure that we understand what works well for participants and what doesn't work well. So what we want to deliver as a result of phase 3, which we're just, as I say, just starting to plan, over our next year's work is to develop some learning materials to support the understanding and implementation of remote methods of trial delivery, particularly for delivery teams, resources to support the dissemination, communication and building trust in those methods. So we will iterate our website, we might have some blogs, that sort of thing, podcasts, and we will have a dissemination event at some point again over the next year. And we also need to think very carefully about how we're going to measure the impact of increased awareness, understanding and implementation of these methods across our trial delivery landscape. So I'll leave it there. Thank you very much for your attention.